Good evening, friends. Today our guest speaker is Dr. Steven Swadlow from Pittsburgh. He's going to speak to us on the international consensus classification of malignant lymphomas and update. This webinar is brought to you by Mumbai Hematology Group. It is supported by NATCO and managed by Perfect Square. I thank Mr. James Rajakumar and team from NATCO, Mr. Yash, Mr. Kalpesh and the team from Perfect Square, the Executive Committee of Mumbai Hematology Group, our guest speaker, Dr. Steven, all our discussants who are themselves eminent hematopathologists, new participants for sparing your Saturday evening, if you are from India, morning or afternoon from the rest of the world. We have registrations today from 27 countries. Just to introduce you for the tomorrow morning webinar, Sunday, 11:30 a.m., we have Professor Raki Kar from JIPMA speaking to us on myeloid neoplasms with striking erythroid hyperplasia, a case-based approach. So do log in. Next week, we have an update from EHA, which was held 2 weeks ago, the 27th Congress of European Hematology Association. This will be a 1 week-long webinar from 4th to 10th of July, from 6:30 p.m. to 9:30 p.m. There will be 3 lectures every day, total of 21 lectures by 21 international guest speakers. So keep your evenings free from 4th to 10th of July for EHA update. Our discussant this evening, and we have 16 of them with us. They are all eminent personalities. Introduce them briefly. Dr. Akhila from Majumdar Shah Medical Center, Bangalore. Dr. Amanjit Bal from PGI Chandigarh. Dr. Amrita Saraf from Gangaram Hospital, Delhi. Dr. Ankur Ahuja from R&R Army Hospital, Delhi. Dr. Devdeep Dev from TMC, Kolkata. Dr. Sridhar Yapari from TMH, Mumbai. Dr. Jay Mehta from Center of Oncopathology, Mumbai. Dr. Jyoti Bajaj Sarne from GCRI, Ahmedabad. Dr. Parimal Sarda from Hemato-Oncology Clinic, Vedanta, Ahmedabad. Dr. Sandeep Sheth from Zadas Hospital, Ahmedabad. Dr. Shashi Bansal from Bhagwan Mahavir Cancer Hospital, Jaipur. Dr. Sindhura Lakshmi KL from Kasturba Medical College Hospital, Manipal. Dr. Sumit Gujral from TMH, Mumbai. Dr. Tanuja Sheth from TMH, Mumbai. Dr. Tara Roshni Paul from Nizams, Hyderabad. And Dr. Udyan Kachi from Udyan's Lab, Vadodara, Gujarat. It's my pleasure now to introduce our guest speaker for the day. Does not require introduction to the audience who have logged in today to hear him. He has been to Mumbai, he has been to India, he has been giving lectures to us through webinars during last 2.5 years, and he is a tremendous personality, a big, huge name in the field in which he's going to speak to us today. To complete the formalities, he's Professor of Pathology, Director, Division of Hematopathology, University of Pittsburgh School of Medicine, UPMC Presbyterian, Pennsylvania. He received his BA from Brandeis University, MD from Harvard, residency training in pathology at Beth Israel Hospital, Boston, fellowship training in hematopathology at Vanderbilt University Medical Center, St. Bartholomew Hospital, London. It's published over 200 original articles in the area of research. Lead editor of the last 2 WHO classification of tumors of hematopoietic and lymphoid tissues blue books, co-edited pediatric hematopathology and wrote biopsy interpretation of lymph nodes. In addition, he has written numerous chapters and invited reviews in hematopathology and given invited lectures around the world. He is the past president of the Society for Hematopathology, serves on the editorial board of 2 major pathology journals, is past president of the American Board of Pathology, is on the steering committee for the International Consensus Conference for revision of our current lymphoma classification. He received the inaugural Gerard Dorfman Founders Award for a senior hematopathologist from the Society of Hematopathology and the Harvey Goldman Master Teacher of the Year Award from the US CAP. I invite him to deliver his lecture on the International Consensus Classification of Malignant Lymphomas and update. Thank you. And over to you, sir.
Thank you very much. Can you see my screen?
Yes, sir.
Wonderful. So thank you so much for inviting me today. Thank you so much for the nice introduction. And I do have to take this opportunity once again for thanking you for your wonderful hospitality when I was actually physically in Mumbai. I have nothing, whoops, make sure we can advance this, whoops. I have nothing to disclose here as I'm sitting in my office. And the last time that we got together, I talked about evolving lymphoma classifications. And we talked a lot about the past and sort of what was going on in terms of the developments. And we sort of looked at what the future might be like. But today we're looking at sort of the here and now and the international consensus classification of malignant lymphomas. For those of you who might have not been with us last time or want a refresher, just to mention very briefly today, I mean, we all recognize that our 2016 WHO classification that was put into the 2017 monograph is in need of updating and revision. And unfortunately, this revision is taking place along two separate pathways. The pathway that you see on the right is the one that's basically being led by those who've been involved in this process for decades, although some people have retired. And we did add the presidents at the time of the Society for Hemopath and the European Association for Hematopathology to our pathology steering committee. And as in the past, we have worked very closely and consider it very important to work with our clinical advisory committee, which includes prominent clinicians from really around the world. And this is what's leading to the international consensus classification. The other pathway, route, track, which is the one that you see on the left, is led by IARC and its standing editorial board, which does include one hematopathologist. The head of it, though, really is Dr. Ian Cree, who is an ophthalmic pathologist. And then there is an expert editorial board that I realized does include one of our expert discussants from today. And basically, I mean, Dr. Cree has sort of a different philosophy about how this should be done. And in a very recent email, he indicated how there was potential for bias in the consensus approach, which I guess he does not like. Anyway, our plan then for today is really to introduce you to the 2022 International Consensus Classification of Mature Lymphoid Neoplasms, which I would argue is the direct descendant really of the 2016 WHO classification. We're going to look at the most important aspects of this new classification of mature lymphoid neoplasms. It is a classification not written from scratch, but clearly based on the 2016 WHO classification and the deliberations of the 2021 Clinical Advisory Committee meeting. That manuscript, which is now available online, also includes these tables that highlight the changes in the international consensus classification. And obviously, we have no time to go over everything today, and we can't discuss really anything in any degree of detail. I would like to mention that our paper is dedicated to the memory of Paul Kleihuis, who's the former director of IARC, who recently passed away. He was a visionary leader, as it says, who created the modern WHO Blue Book series for the classification of tumors and was a very strong supporter of the approach that we continue to take. I just, in terms of fact checking, I mean, I don't know how many of you may have seen a very recent editorial that he wrote in Leukemia together with his classifications, where he wrote, unfortunately, despite the fact that the CAC was a self-appointed group, it had nevertheless been allowed to take over the production of the 4th edition and to produce another 4th edition revised version. And I just want to point out very briefly that it's actually that IARC who invited the Society for Hematopathology to develop the WHO hematolymphoid classification. It did not work the other way around. The Clinical Advisory Committee is not self-appointed, but it grew out of the Society for HemePath and EAHP collaborations, and there was definitely no takeover. I mean, the production to the end remained under the control of Paul Kleihuis and IARC. I mean, you can see in these pictures that are right before the 2017 Blue Book was finalized. That's Dr. Paul Kleihuis on the left with Marcus Fessler, who did the layout. I mean, working on the final aspects of this. I mean, I was there together with Elaine Jaffe and Nancy Harris. We had a nice lunch afterwards, as you can see, with Dr. Kleihuis. And then that's my wife smiling at you as well. So the only other thing I want to point out is that our current paper that is in Blood is basically similar to our 2016 paper, except of course, it is updated for 2022 and has an updated classification. As we then go through the highlights of our new classification, you do want to consider the following. There are newer diagnostic entities to recognize, although actually those are fairly limited. There are changes in our diagnostic criteria for previously recognized entities or new subtypes. And there are suggestions for evaluation of some specific entities beyond sort of the basic diagnosis. We're going to begin with the B-cell lymphomas and spend most of our time on those. I mean, where there are really the biggest changes, I think. In terms of CLL and monoclonal B-cell lymphocytosis, our basic criteria do remain the same. As also highlighted in other guidelines, mutational status of the IGHV and TP53 alterations need to be evaluated at the time when patients require treatment. We still recognize tissue-based monoclonal B-cell lymphocytosis, although now with greater certainty using our previously reported criteria, but there have been subsequent publications that have further supported this. What is new and not previously known is that before diagnosing Richter's transformation of CLL, you do need to exclude changes that can be related to temporary discontinuation of ibrutinib and which are reversible. In terms of splenic marginal zone lymphoma, we recognize the current reality, but also look towards the future. It is pointed out specifically that splenic marginal zone lymphoma cannot be diagnosed based solely on the extent of bone marrow or peripheral blood involvement. You do want to remember about non-CLL type monoclonal B-cell lymphocytosis, even when the lymphocyte count sometimes is more than 5,000, and it is said that you now need clinical or imaging evidence of splenic involvement before you diagnose an overt lymphoma. The distinction of splenic marginal zone lymphoma from splenic diffuse red pulp small B-cell lymphoma would require, though, evaluation of splenic histology if you need to make that distinction. And again, it looks to the future and realizes there are unknown sort of questions here in terms of genetics and more sophisticated immunophenotypic studies, again, looking for so-called therapeutic vulnerabilities. But that's for next time. In terms of lymphoplasmacytic lymphoma, there are new criteria for the diagnosis versus IgM MGUS when you have a bone marrow to examine. Currently, you can have up to 10% lymphoplasmacytic infiltrate in the bone marrow and still call it IgM MGUS. But basically, it was decided to reinstate older recommended criteria, actually from almost 2 decades ago. Namely, that if you do have histologic infiltrates with B cells and plasma cells, neoplastic ones, that would then require the diagnosis of LPL rather than IgM MGUS. You do need to exclude reactive lymphoid aggregates. If they're just scattered light chain restricted plasma cells, that would also be considered insufficient for the diagnosis. And if you only have light chain restricted B cells or plasma cells by flow in the absence of histologic lesions, that is also considered insufficient to diagnose an overt lymphoma. Assessment for MYD88 and CXCR4 mutations is strongly encouraged in the workup of suspected lymphoplasmacytic lymphomas. Even if not specific, looking for the MYD88 L265P mutation is considered diagnostically useful. We have learned that we need to be extra careful, though, about the wild type cases but they do definitely exist, and they seem to be more aggressive. Use of an allele-specific PCR for the MYD88 mutation is considered more sensitive than most NGS assays and is therefore recommended because the extent of involvement in the bone marrow may be limited. Routine assessment of CXCR4 mutations is also strongly encouraged, as particularly the nonsense variants have been associated with symptomatic hyperviscosity, other clinical features, and a resistance to ibrutinib therapy. In terms of IgM MGUS, you do want to remember the new LPL criteria. We also now recognize two types of IgM MGUS, a very rare plasma cell type, which is considered a myeloma precursor and where you see clonal plasma cells without a lymphoid component and or myeloma type cytogenetics. These cases would not have a MYD88 mutation. And then there's basically all the other cases of IgM MGUS not otherwise specified, which is a more heterogeneous group that could be a precursor to a variety of different neoplasms, including but not exclusively LPL. Primary cold agglutinin disease is now recognized as a new diagnostic entity considered distinct from LPL or IgM MGUS. In terms of the plasma cell neoplasms, here we have another change back to the past. Plasma cell myeloma is out and multiple myeloma is back in again. I mean, which is something I think many people are sort of relieved about. Cases of myeloma now, according to our classification, do require cytogenetic categorization, as you see on the right, with most cases in one of the categories with recurrent genetic abnormalities. MGUS of non-IgM type is, it doesn't always proceed to a neoplasm, a more overt neoplasm, but it is considered a universal precursor to myeloma. Most of these patients will be asymptomatic, but the category also does include cases of what has been called monoclonal gammopathy of renal significance or of clinical significance. In terms of plasmacytomas, we still have solitary plasmacytoma of bone and extraosseous plasmacytoma, but in addition, we're told that we need to designate if it is with or without bone marrow involvement, because bone marrow involvement is associated with a higher risk for progression, at least for the solitary plasmacytomas of bone. And it is recommended that flow studies be done because the involvement, as you can see, may be very limited. In terms of amyloid, the name for primary amyloidosis has been changed to immunoglobulin light chain amyloidosis, and a localized form has been specifically identified that does need to be distinguished from the more systemic kind of light chain amyloidosis. These cases of amyloid tumors are similar in some cases to what others have called malt lymphoma associated with localized amyloid. Follicular lymphomas. These, of course, were recognized over a century ago, although not necessarily always called a lymphoma. But when you look at the images, this is basically what we're still recognizing today. And here, we still have an ongoing headache of grading follicular lymphomas and some other ongoing uncertainties. We have really no real changes here, but there is some limited additional guidance and concerns. Whether grade 3A follicular lymphomas are more aggressive and should get treated differently than the low-grade follicular lymphomas is considered debatable. Grade 3B follicular lymphomas, though, do differ clearly from low-grade follicular lymphomas and are usually managed more like a diffuse large B-cell lymphoma. Therefore, it is important to distinguish the grade 3A from the grade 3B follicular lymphomas, and our publication does provide some guidance, namely, if you're sort of going back and forth and you're not quite sure if it's 3A or 3B, if you do find BCL2 rearrangement and CD10 positivity, that is said to favor a grade 3A follicular lymphoma. The other thing that you can see in this figure is that if you're contemplating diagnosing a grade 3B follicular lymphoma and you see a lot of IRF4 MUM1 positivity, then it is recommended that you do IRF4 FISH looking for evidence of a large B-cell lymphoma with IRF4 rearrangement. People, have written and been concerned about follicular lymphomas with a double hit, namely BCL2 or BCL6 rearrangements in addition to MYC. But here, routine screening is not required to look for these. They are definitely not to be included among the other high-grade B-cell lymphomas. And the consensus from our meeting was that these cases might have a more aggressive outcome. In terms of mutational profiling in follicular lymphomas, there's really limited utility at the current time. Detection of EZH2 mutations does provide additional information when treatment with an EZH2 inhibitor is being considered, although some patients that don't have the mutation still respond to the inhibitor. BCL2 non-rearranged follicular lymphomas, well recognized, are heterogeneous, but we do have a new provisional entity here for a distinctive subset that we have named BCL2 rearrangement negative, CD23 positive follicle center lymphoma. But this basically is what was formerly known in the 2016 WHO as the diffuse variant of follicular lymphoma. These cases are characterized by these 6 features. And the name simply includes 2 of these features, but these are all features that characterize this disease. Although, as you can see here, the reported frequency of each of these defining features varies depending on sort of the inclusion criteria that have been used in the different published studies. And not all of the typical features are present all of the time. So it's just like everything else in our business. You have to put a constellation of features together before you can really decide what you're dealing with. Testicular follicular lymphoma has been a variant. It was considered important enough to become a distinct entity. These, of course, are not very common. Large B-cell lymphoma with IRF4 rearrangement has been upgraded to a definite entity. This is a rare lymphoma that occurs mostly in children and young adults, with adult cases similar, but with some more genomic complexity, and the adult cases are more often of ABC type. The more you look for these, the more you'll find, including in adults, but you also need to be aware that IRF4 rearrangement can be a secondary event in other kinds of B-cell lymphomas. Mantle cell lymphoma. This is a lymphoma, that we were taught for so many years was hopeless. We now recognize that it's not always hopeless. Leukemic non-nodal mantle cell lymphoma is, of course, nothing new for now, but its recognition is further emphasized, even if it is considered a subtype of mantle cell lymphoma and not a different entity. You do need to use a multi-parameter approach to its recognition, incorporating both clinical and pathologic features, with the features favoring this diagnosis listed here. Remember, however, though, that although it is considered one of the more indolent types of mantle cell lymphoma, that TP53 alterations and genomic complexity do confer an adverse prognosis in these cases, which can be extremely aggressive. There is a subset of other mantle cell lymphomas that overlaps with this leukemic non-nodal group of cases and which mimics CLL both morphologically and phenotypically. So if you look at the features that I have listed here, you would think you were talking about CLL, but in fact, all of them can be found in a subset of mantle cell lymphomas and often with more than one of these. With better understanding of cyclin D1 negative mantle cell lymphomas, the definition of mantle cell lymphoma is now broadened to specifically include cases that have cyclin D2 or D3 rearrangements, as long as the morphology and phenotype, including SOX11 positivity, are like what you would see in classic mantle cell lymphomas. There is also increasing awareness, though, of secondary cyclin D1 rearrangements that can be found in other kinds of lymphomas. These are excluded from the category of mantle cell lymphoma, but on the other hand, you do need to recognize that mantle cell lymphoma may have MYC rearrangements, and some of them even BCL6 aberrations. Mantle cell lymphomas that have cyclin D1 and MYC rearrangements are aggressive, but they are not included among the classic double hit lymphomas. Occasional cases of these may even have TdT positivity, but I mean, today we would not consider them truly lymphoblastic, as you can see in the paper illustrated on the left. The expected workup with mantle cell lymphomas, preferably at diagnosis, in order to identify the more aggressive cases includes a morphologic assessment looking for blastoid or pleomorphic cases, doing immunohistochemistry to see if the Ki67 is at least 30% or higher. And it is specifically said that estimating this proportion is considered okay. And then looking for TP53 deletions and mutations. Moving on to the more classic sort of aggressive B-cell lymphomas. Diffuse large B-cell lymphoma remains a heterogeneous group of cases. We know about the morphologic variants. We know about the phenotypic variants. We know about the cell of origin issue with its prognostic implications, which is really old news. And there are certainly some studies that don't even demonstrate an impact on outcome, even using gene expression profiling. What was more important in 2016 was the belief, though, that cell of origin had potential therapeutic implications. Subsequent studies, though, have not been so promising, and this is further emphasized in the ICC publication. As we move forward, and for today, the morphologic and phenotypic variants are really downplayed in our publication, but cell of origin is being retained at the moment. However, according to the ICC, this lack of predictive power of the cell of origin really highlights the importance of a more molecularly based approach. And if you look in this figure from our paper, when it comes to the future of clinical practice, you can see incorporating mutational and additional cytogenetic data so that one can have more personalized therapies. This molecular and genetic classifications of diffuse large B-cell lymphoma, I covered it in more detail the last time that I spoke here. There are 5 to 7 partially overlapping categories here that have been defined by 3 different groups that have biologic, prognostic, and potential therapeutic implications. And I would just point out again that you can't use just a single mutation to identify really any of the groups, even if they bear their name, like a MYD88 mutation. These are definitely not ready for prime time yet. Many of these classifiers do leave a significant proportion of cases unclassified. Some of them, but not others, use cytogenetic findings in addition to the mutational studies. And maybe at the end of the day, these will be most useful to guide targeted therapies rather than simply for prognosis. Partially, though, based on the findings in these studies, one new entity was pulled out from other diffuse large B-cell lymphomas, namely primary diffuse large B-cell lymphoma of the testis, which has many features that sort of overlap the primary CNS lymphomas. And even if they're not ready for prime time, these molecular and cytogenetic groups are really becoming a part of our current vocabulary and a part of clinical investigations, as you can see here. It was pointed out then in an editorial a couple of years ago, actually, it seems inevitable on the basis of the results of the molecular genomic classification studies that a more detailed genetic subclassification is poised to supersede the cell of origin framework. And in our publication, we point out how overall cell of origin is retained for the present time with the expectation that transition to a molecular genetic classification will be feasible in the near future. Burkitt-like lymphoma with 11q aberration has become large B-cell lymphoma with 11q aberration. We now recognize that these cases are very distinct from Burkitt lymphoma in terms of their mutational profile and cytogenetic characteristics. This is still considered a provisional entity. Some of these cases are actually composed of larger cells, as seen here. And another clue to these cases, before any cytogenetics is done, is the coarse apoptotic bodies that you see illustrated on the far right. HHV-8 negative effusion-based lymphomas are not to be considered a type of primary effusion lymphoma. That statement is not new. It's what we've got now, but we recognize that these make up a heterogeneous group of cases that include a distinct subset that has certain clinical pathologic features that should be recognized. These group of elderly patients with fluid overload have involvement of pleural, pericardial, or least frequently abdominal cavity. And in these cases, drainage sometimes may actually be sufficient therapy with good outcomes. This subset is a new provisional entity known as HHV-8 negative and EBV negative primary effusion-based lymphoma, with the other HHV-8 negative effusion-based lymphomas classified based on the type of lymphoma that they otherwise would represent. In terms of the EBV positive lymphoproliferative disorders, we have the introduction of a really not so new term, but it is one that's now considered acceptable to use, although it is not actually an entity, namely EBV positive polymorphic B-cell lymphoproliferative disorder. This is to be used for EBV positive B-cell proliferations with or without known immunodeficiency that cannot be more precisely categorized. The term, though, should be reserved for cases with altered lymph node or other architecture and a polymorphic infiltrate that do not fulfill the criteria for the diagnosis of lymphoma or where there's uncertainty due to the small size or low quality of a biopsy. Lymphomatoid granulomatosis now requires pulmonary involvement. Otherwise, you have to make some other kind of a diagnosis. EBV positive mucocutaneous ulcer promoted to a definite entity. It is emphasized, though, that these are single lesions. And if you have multiple lesions, then you're dealing with something else. And if you can't precisely categorize them, then you just call it an EBV positive polymorphic lymphoproliferative disorder. It was actually recently pointed out in a publication that it is difficult to distinguish EBV mucocutaneous ulcer from EBV positive diffuse large B-cell lymphoma using only pathological and genetic findings, suggesting that clinical information is important in accurately distinguishing these two entities. Moving on then to the high-grade B-cell lymphomas, this is a summary of our current approach, but there are several issues here in need of revision. We have a new category. Note it's a subtle change, namely high-grade B-cell lymphoma with MYC and BCL2 rearrangement. This excludes cases that have MYC and only a BCL6 rearrangement. This is now felt to be a more homogeneous category. It does include the triple hit lymphomas, so there may, in addition, be a BCL6 rearrangement. Morphologic assessment is still required, so don't get rid of those old microscopes. You can see that the cases that look high grade do seem to be more aggressive. There is conflicting data out there regarding the clinical impact of the MYC partner, so that is not required for diagnostic purposes. If you just have extra copies rather than rearrangements of MYC and BCL2, those continue to be excluded from the double hit lymphoma category. High-grade B-cell lymphoma with MYC and BCL6 rearrangements then is a new separate provisional entity because, again, it is considered biologically different from the BCL2 double hit lymphomas, and it doesn't share a similar gene expression profile. Survival curves, though, for BCL6 versus BCL2 double hit lymphomas, they certainly do vary, but many of them do show that BCL6 double hit lymphomas are at least as aggressive. And so, I mean, we don't want to just lump them together with other diffuse large B-cell lymphomas at this time. High-grade B-cell lymphoma, not otherwise specified, is a heterogeneous category. It remains a diagnostic option for B-cell lymphomas, as illustrated here, that might have blastoid or more Burkitt-like morphology, but it is a diagnosis that you are to use sparingly. And just because you might have a starry sky or you might have a high proliferative fraction, those are not criteria for this diagnosis. Another major change with the high-grade B-cell lymphomas grew out of these two and other studies, namely that some high-grade B-cell lymphomas do have at least some TdT expression and other markers of immaturity, but they need to be CD34 negative. But the point is, these are not to be called then B lymphoblastic neoplasms, but they are, as you can see on the right, very aggressive. And the suggestion is that in these cases, you diagnose your high-grade B-cell lymphoma and then add into your diagnosis with expression of TdT. Many of these cases represent transformations and do have a blastoid cytology. But just to keep everybody on their toes here, what was called TdT-positive Burkitt leukemias, I mean, they're in the 2017 Blue Book, and some of those are even CD34 positive. Those, on the other hand, now should be diagnosed as B lymphoblastic leukemia lymphoma, again, with additional studies showing a greater similarity to the lymphoblastic neoplasms rather than Burkitt lymphoma. In terms of Hodgkin lymphomas, there's really no change for classic Hodgkin lymphoma, but the big change here is that nodular LP is no longer included among the Hodgkin lymphomas and renamed nodular lymphocyte predominant B-cell lymphoma. This is because of its major biological and clinical differences from classic Hodgkin lymphoma, its close relationship to T-cell histiocyte-rich large B-cell lymphoma, and because it has then therapeutic implications. Still, we're supposed to identify variant patterns, but they've been slightly reorganized in that patterns A through C, or grade 1, are considered classic, and D through F, the variant patterns, or grade 2. And the comment is specifically made that the grade 2 cases may warrant therapy as a diffuse large B-cell lymphoma. Thymic has been removed from primary mediastinal large B-cell lymphoma. The name, I mean, nobody used that anyway. There are some newer tools out there to help with the diagnosis, and there are still some areas of difficulty and confusion here that need to be further resolved. B-cell lymphoma unclassifiable with features intermediate between diffuse large B-cell lymphoma and classic Hodgkin lymphoma. That name is gone. So now we're dealing with mediastinal gray zone lymphoma. It's more than just a welcome name change. This is a diagnosis to be used only for mediastinal cases, with genomic and clinical data supporting that most of the what were called non-mediastinal gray zone lymphomas are distinct from mediastinal gray zone lymphoma and should be diagnosed as a diffuse large B-cell lymphoma NOS. Similarly, the EBV-positive diffuse large B-cell lymphomas are different and still need to be segregated. There's a separate little section on the cutaneous B-cell lymphomas, consistent actually with older cutaneous lymphoma classifications. Primary cutaneous marginal zone lymphoma has been extracted from the other MALT lymphomas. It is now a lymphoproliferative disorder rather than a lymphoma. This is an extremely indolent disease, although cutaneous recurrences are common. We do recognize two subtypes distinguished largely based on whether they are class chain switched or IgM positive. There are other pathologic differences as well. The IgM subtype does require greater concern about the possibility of concurrent or subsequent extracutaneous involvement. Primary cutaneous follicle center lymphoma has a distinctive mutational landscape, we have learned, which further highlights why they should be segregated from other follicular lymphomas or diffuse large B-cell lymphomas. And it also has provided another tool in our diagnostic armamentarium to use in difficult situations or to help predict synchronous or subsequent extracutaneous dissemination. We still have primary cutaneous diffuse large B-cell lymphoma leg type. It remains a distinct entity, although many of the cases actually share molecular and cytogenetic features of the MCD type of diffuse large B-cell lymphoma. These are generally considered to be of ABC type, but actually a recent study suggested their cell of origin is more variable, and there are rare reported cases that are also TdT positive. With that said, it's now tea time. We don't have much time left at all here. And in fact, the CAC discussions focus just on those areas in which new insights into the pathogenesis and clinical behavior have occurred. And we obviously don't have much time to go over this here today. In terms of the EBV positive T and NK cell lymphoproliferative disorders of childhood, There have been a number of changes, as you see. Hydrovacciniform lymphoproliferative disorder, the like is we've gotten rid of that. And there are now two forms, a classic form and a more systemic form. Chronic active EBV disease, it's called now disease, not infection. I mean, because many people have chronic EBV infection, and are perfectly healthy. And it is a diagnosis restricted to cases with a T and NK cell phenotype. Primary nodal EBV-positive T and K cell lymphoma has been moved from a variant of PTCL-NOS to being a provisional entity. This is a rare aggressive systemic lymphoma with adenopathy and without nasopharyngeal involvement that has a CD8, usually positive, CD56, usually negative phenotype, which is distinct from extranodal NK T cell lymphomas, and also distinct, these are usually of T cell origin. They have a dismal outcome. Among the intestinal T cell lymphomas, type 2 refractory celiac disease is added to the classification just as a precursor of enteropathy-associated T cell lymphoma. There are some newer aids out there in the differential diagnosis of enteropathy-associated T cell lymphoma from monomorphic epitheliotropic intestinal T cell lymphoma, but I don't think any of these are in widespread use. I know we're not using them. And there are some changes in the indolent lymphoproliferative disorders of the GI tract as well. We now have indolent clonal T-cell lymphoproliferative disorder of the GI tract as a distinct entity. And I mean, the word clonal is added, even though that's not a new finding, just to make it perfectly clear that these are, for the reasons that you see here, certainly to be considered neoplastic. We've added indolent NK cell lymphoproliferative disorder of the GI tract to the classification as well. Again, this is not something new, but it's new for the classification and with a new name. This is what was formerly called NK cell enteropathy or lymphomatoid gastropathy. In 2016, the non-cutaneous T follicular helper cell lymphomas were put under one larger umbrella known as angioimmunoblastic T-cell lymphoma and other nodal lymphomas of TFH origin. So now we have a similar umbrella, but the classification and terminology are altered slightly to highlight even further how these lymphomas, which have a common genetic landscape, are a spectrum and not three like totally different entities. So now we have follicular helper T-cell lymphoma, angioimmunoblastic type, follicular type, or just not otherwise specified. Here, I mean, TET2 and DNMT3A mutations are emphasized, although you have to be careful because they're also found in CHIP. The variant allele fraction and the number of variants might be helpful. And we also recognize, though, that AITL can arise in a background of clonal hematopoiesis. RhoA and IDH2 mutations are also seen in the TFH lymphomas, especially angioimmunoblastic T-cell lymphoma, which are also important. And this is one of the situations where doing molecular testing is considered valuable in supporting the diagnosis, and it might be a more sensitive way if you need to sort of further prove that something is neoplastic rather than clonality testing. The IDH2 R172 mutated angioimmunoblastic T-cell lymphomas have been reported to have unique features. This is the mutation most strongly associated with the AITL type of TFH lymphoma. These cases have a distinct gene expression profile and characteristically have medium to large clear cells and particularly strong CD10 and CXCL13 expression. In terms of the NOS cases, I mean, the word nodal is not used in our classification, but the category does exclude primary cutaneous small medium CD4 positive T-cell lymphoproliferative disorder and other specified subtypes of cutaneous lymphomas that might have a TFH phenotype. Especially here, demonstrating the TFH markers is critical, really. With a 5-marker recommended panel, you need at least 2 of these to be positive, and it's better if at least 3 are positive. RhoA and IDH2 mutations, if they're present, may also be helpful in this setting. ALK-negative anaplastic large cell lymphoma, we now recognize the DUS22 rearranged cases as a distinct genetic subtype, and the recommendation is to do FISH in these cases to identify these cases that have a usually but not always favorable prognosis. TP63 rearrangement remains an adverse prognostic indicator here, but there's too little data to really be considered a distinct genetic subtype. Our paper does specifically discuss JAK2 rearranged CD15 positive, CD30 positive, anaplastic cytotoxic T-cell lymphomas in this section on ALK-negative anaplastic large cell lymphomas. These, as illustrated, can really mimic classic Hodgkin lymphoma closely, but they are PAX5 negative. So, I mean, I mention it here today just because you should really be aware of PAX5 negative, cases that you're thinking about classic Hodgkin's that actually are a cytotoxic clonal T-cell neoplasm. Breast implant associated anaplastic large cell lymphoma is now a definite entity. I mean, the existence of these cases led the United States FDA to call for a voluntary recall of selected breast implants. It has been more recently discovered that these have a characteristic cytogenetic finding. Subcutaneous panniculitis like T-cell lymphoma, I mean, there's no change here, but there is new important genetic information, namely that many of these cases do have CR2 germline mutations. Primary cutaneous acral CD8 positive T-cell lymphoma, now to be considered a lymphoproliferative disorder. These cases are very indolent, even though they look bad, but there haven't been disease-related deaths, although a fifth of them that have been reported have had cutaneous recurrences or progression, with one case at least that had extracutaneous involvement. And this is true no matter how the patients have been treated. And then you get to PTCL-NOS. It is a diagnosis of exclusion. There is this figure in our paper, which is a suggested way that you can think about the peripheral T-cell lymphomas. Basically, you go through this whole list, excluding the different specific types of mature T-cell lymphomas, and then you end up with PTCL-NOS. The two molecular subgroups, which you see here, and which have prognostic implications in general, and which actually are already recognized in our current Blue Book, are again noted, but their recognition is not routinely incorporated into clinical diagnosis and does require further studies for clinical validation. And there are some subsets of those that actually don't behave as expected. I just want to mention our classification of the immunodeficiency associated lymphoproliferative disorders. Here are in the ICC, the PTLD classification remains the same. We did not adopt the Heme Path Society's workshop recommendation to no longer segregate the PTLDs. We really feel that they should remain separate. There is a discussion in the literature if we should also include EBV negative malt lymphomas now as a PTLD. That was not dealt with by the CAC. It'll have to be dealt with at a later date. And in terms of other iatrogenic immunodeficiency associated lymphoproliferative disorders, we try to categorize those now using a scheme similar to the PTLDs. And although there are certainly significant changes compared to the 2016 WHO classification, realize, I mean, we're not discussing the histiocytic dendritic cell neoplasms here today. We're certainly not discussing the myeloid and lymphoblastic neoplasms, but you can find their paper, which is now in press in Blood. I'm not sure if it's available electronically yet, but it has been accepted for publication. And with that said, I'm going to conclude. We talked about briefly the two-track revision of our current classification with the 2022 IC classification, the one that's the more direct descendant of our current WHO classification, even if it's not under the umbrella of WHO IR. It is a collaboration of the Society for Heme Path, EAHP, and the important clinicians of the CAC from around the world. We spent most of our time reviewing the changes in that classification compared to the classification that we all have now. and we've seen how they will impact our practice of hematopathology with some new entities and subtypes, with revised criteria and nomenclature for some existing entities, with new information that impacts our understanding and evaluation of selected lymphoid neoplasms. And as already seen, and as is obvious, there is much left to be learned. Remember, our ultimate goal remains improved outcomes and quality of life for those with lymphoid neoplasms, hopefully without causing too much grief for hematopathologists and hematologist oncologists. As I conclude further, I do want to thank the other members of the ICC Lymphoid Steering Committee. I want to thank the members of the Clinical Advisory Committee and the hematopathologists who were an integral part of the IC conference. I want to thank those who gave up the opportunity to participate in the 5th edition of the IARC Blue Book series to support the CAC route, even if they weren't even directly involved in it. I, of course, want to thank the numerous individuals whose efforts have provided the concepts and basic knowledge base that have led to where we are today. And I want to thank all of you for participating today and coming. It doesn't make any difference whether you worked on the ICC, whether you worked on the WHO classification, or neither. I mean, we are one big hematopathology family, and it's really been a pleasure to be with you again today. So thank you so much for your attention.
Thank you, sir, for that masterly presentation. A piece of very great hard work which has gone on, and the way you put it up in such a short period, tremendous amount of data and update. Thank you so much, sir. So we got all these colleagues over here who must be very keen to ask you questions. We will use the raise hand sign. Until that happens, I'll put some questions from the audience to you. We have 2 questions already. Dr. Francisco wants to know, how are we going to diagnose DLBCL morphology with DLBCL phenotype, except negative or weakly positive for CD20? Can I call it gray zone?
So I guess the basic question is, if you have weak CD20 and a diffuse large B-cell lymphoma, is that a sufficient piece of information to call it a gray zone lymphoma? And I guess my short answer would be that the diagnosis of a gray zone lymphoma, which is actually one of the more difficult diagnoses that we have to make, is one that requires more information than just a weak CD20. I mean, first of all, as currently defined now, we want to restrict the diagnosis of a mediastinal gray zone lymphoma to those that are in the mediastinum. That's the first thing. And second thing, I would say that they basically would have to have more features that made you worry about classic Hodgkin lymphoma than just a weak CD20. Because, I mean, we recognize there are some diffuse large B-cell lymphomas, especially the ones as they begin, I think, to get more aggressive, that may have diminished CD20 staining.
Thank you, sir. The other question is from Dr. Kadir. Is nodular lymphocytic predominant Hodgkin lymphoma removed from WHO upcoming classification?
So, I mean, basically, it's moved to a different location and the name was changed. So, I mean, nodular, what we've been calling nodular LP Hodgkin lymphoma, I mean, it obviously still exists, but we decided that for the reasons that I sort of mentioned briefly, that it would be better considered nodular lymphocyte predominant B-cell lymphoma. So it's moved into the group of B-cell lymphomas because I think a lot of people feel that those cases sort of, I mean, they're biologically very different. I mean, we all know the cells mark like the cells of other kinds of B-cell lymphomas. And it's a lot, I mean, some of the cases are a lot like T-cell histiocyte-rich large B-cell lymphoma. And I mean, if I know there was one of the questions you sent me in advance about treating some of the cases. I mean, I think the treatment, at least in the eyes of many, is different than the way you would treat classic Hodgkin lymphoma. I mean, the more aggressive cases, the more widely disseminated cases, I mean, there's certainly been a literature about treating them more like a diffuse large B-cell lymphoma. And I mean, for the lower, the grade 1 lesions, the ones with a more classic pattern, I mean, it depends on, again, how extensive the disease is. I mean, you know, the ones that are actually localized, especially in younger individuals, I mean, some of those patients are just, you know, followed if it's been surgically excised, and others are treated in ways, again, that would be different than what you see with classic Hodgkin lymphoma.
Thank you, sir. So now we'll go with the raise hand sign in the order in which it has been raised. Dr. Jai Mehta, please.
Dr. Swaglo, my question is regarding the TdT-positive large B-cell lymphomas. So what's the trigger on morphology that you would use to put up a TdT for a high-grade B-cell lymphoma, a mature high-grade B-cell lymphoma?
So, I mean, the question is, when would we do a TdT stain? Yeah. So, I mean, basically, most of those cases would have some morphologic features that make you think about a lymphoblastic lymphoma. I mean, you know, more chromatin dispersal rather than sort of vesicular chromatin with a nucleolus, you know, a very high proliferative fraction, features like that. I mean, we do a lot more TdT stains than we used to, because we think that it is worthwhile recognizing those cases, even if they're not lymphoblastic. But I mean, we certainly don't do a TdT stain in every diffuse large B-cell lymphoma. So we're basically looking for, you know, pretty standard sort of high grade features, or if we've got other sort of phenotypic suggestions that of immaturity, then we might do a TdT stain. I mean, if there was like flow information and the CD20 was dim, then that would be another reason that we might do the TdT stain. Because we've seen some cases where it's sort of a gradual transition where you might have like less CD20 staining, maybe some dimmer CD45. I mean, if you've done flow, but the TdT is negative, and then the person recurs, and then now the TdT is partly positive. So that maybe can give you some idea of when we do it and why we're bothering.
Thank you very much.
Sure.
Thank you, Jay. Dr. Amanjit.
Good evening. So I'll continue with Dr. Jay Mehta's question. So because we rely too much on TdT as an immaturity marker, but in a few of your slides, you have suggested using CD34. So my question is, how well CD34 works on tissue sections?
CD34 works very well in tissue sections. It's sensitive, and I mean, you usually have a great internal control because CD34 stains the endothelial cells. So that, I mean, we do use it. We use it a lot. We actually use it, you know, on our bone marrows, you know, looking for CD34 positive blasts, you know, when it's appropriate. And we would use it in the circumstances like where we're considering diagnosing a TdT positive high-grade B-cell lymphoma, because they have the ones that have been reported by us and by others, they have never been CD34 positive. So if we saw CD34 positivity, then we would be talking more about a B lymphoblastic neoplasm.
Right.
And we do like it in paraffin sections.
Okay. Thank you.
Sure.
Thank you. Dr. Ankur.
So good evening, sir. So excellent presentation. And just want to ask a basic question. The cutaneous marginal zone lymphomas have been designated as a separate entity from the extranodal marginal lymphomas. What could be the reason of that? It's because of treatment based, because of the behavior, sir?
Could you repeat that question?
Yes.
Sorry.
Yes, sir. So the cutaneous marginal zone lymphomas have been designated as a separate entity, unlike the other nodal marginal zone lymphomas in the newer classification.
Right. Okay.
Sir.
Yeah, no, I understand the question. That was one of the ones that I saw in advance. So first of all, I mean, from a historical perspective, actually the primary cutaneous marginal zone lymphomas were segregated by the EORTC classification. They were segregated in the WHO EORTC consensus classification, and they were segregated in the WHO classification of the cutaneous lymphomas. So, I mean, that was like inconsistent with having put them together with the other malt lymphomas. I mean, there is a good body of literature specifically about the cutaneous cases, and it has been suggested, I mean, by others along the way, that they seem to be more like a clonal sort of chronic, disease rather than overt lymphoma, because the patients, I mean, the survival, the disease-specific survival approaches 100%, and it's a disease where you see sort of recurrences, but you don't see people like dying of these or the disease particularly progressing. And I mean, another sort of reason is that, I mean, the majority of these cases, the so-called class change switched cases, I mean, they have a lot of differences from typical malt lymphomas. I mean, just in terms of what they look like, the way they mark, their biology. And it's really not even completely clear for the class switched cases whether they're really like a marginal zone proliferation at all. I mean, because a lot of the cases we recognize based on light chain restricted plasma cells. They have a lot of T cells. The B cells that are there are often not very numerous. You see follicles, but the follicles look perfectly normal. So it's really for those reasons. And then, I mean, there is a smaller subset of IgM positive cases that do seem more like other malt lymphomas, although, I mean, they're also extremely indolent. They do share some of the mutations that are seen in the class switched cases. But there was a strong feeling that people did not want to break up primary cutaneous marginal zone lymphoproliferative disorders into two separate categories. So it's really for those reasons that it is segregated now, and why it's called a lymphoproliferative disorder. Again, if you do have a case that's got IgM positivity, you need to be a little bit more careful with it. Be sure it's not secondary, and maybe watch those patients a little more closely.
Thank you, sir. Thank you, sir.
You're welcome.
Thank you. Dr. Tara Roshni.
Good evening, sir. My question is regarding treated or chemotherapy-treated lymphomas. When you look at the response criteria, they're either immunological or clinical. So are there any defined morphological criteria to say whether lymphoma is residual or partially remission or anything like that?
So that's an interesting question. These are all really excellent questions, and ones that I sort of smile at because they're things we all sort of suffer over. So I mean, in thinking about this question, I mean, the only criteria that I know of specifically relate to follow-up gastric biopsies after gastric malt lymphomas. There is like a scoring system, but I don't know that people are really using it. I mean, I don't see it when we get reports from other places. I know we don't particularly use it. It's fairly sort of common sense and quite close to the original grading scheme, from Peter Isaacson that he published, decades and decades ago for gastric malt lymphomas. I think otherwise, it's really a matter of using your standard criteria for, is there lymphoma present? And I guess the only other comments that I would make is that we do recognize that there are some lymphomas, even if you see them before the patient has been treated at all, that are completely necrotic. Like, I mean, you just see necrosis and you don't even see any viable tumor, although that's actually the presenting, tumor. I mean, it's obviously there somewhere. So I would just say, seeing a totally necrotic lymphoma does not necessarily mean that it's been, cured or in remission. otherwise, I think it's just a matter of doing all the things that we do normally to see if lymphoma is present or not. I mean, the only other thing that I would mention, again, it really relates to the gastric malt lymphomas where you can find that the clone is still there, but you can't see anything. And those patients still tend to do well. You know, they can have disease that's basically gone as long as the Helicobacter doesn't come back. So I'm afraid that's the only advice that I could give you.
Thank you.
Sure.
Thank you, Dr. Tanuja.
I'm sorry, my there it is. So thank you, Dr. Swerdlow. That was a wonderful lecture. And just one quick question. And I'm a T-cell lymphoma enthusiast, as you know. And I'm very hurt that angioblastic lymphoma has been put under the category of follicular T helper cell lymphoma. Why not? Because we know today that there is some unique protocols that are used for AITL. So why not give it a distinct, the label? Because people, we call AITL, we don't call it PTCL, AITL subtype, right? So why not retain it? Why use the cell of origin as the label instead of the disease as a label?
So I guess I'll answer your question in a couple different ways. I think the reason for the umbrella, which actually is not something new, although the way the names are is new, is because there are cases that seem like they're sort of a spectrum. So that while, I mean, we all recognize a lot of cases of AITL are very distinctive, there are cases where you have one biopsy that looks more like, you know, just a T-cell lymphoma that's got TFH markers, and then later it looks like classic AITL or the other way around. So that's part of it. I mean, that's actually the reason that they're put under that umbrella. And it's not just the phenotype, because like the cutaneous ones, I mean, you can have mycosis fungoides with TFH markers, but I mean, it clearly, that is not something that goes under that umbrella. And the other thing that I would tell you that I suppose is sort of to your point would be, number one, that just diagnosing a T follicular helper cell lymphoma is not, it's not sufficient. I mean, you need to say what type it is. And if you noticed, of all of them, the only one where it's like it's acceptable to say a specific name is with angioimmunoblastic T-cell lymphoma. So, I mean, because I think it's recognized, I mean, as you point out, you know, that it's sort of the most distinctive. I mean, it's certainly the most common of all of those. So, I mean, if you sign out your case as angioimmunoblastic T-cell lymphoma, you know, I think it's probably still okay and still recognized that some people are going to want to use that terminology by itself. So those are basically the reasons. And I mean, I think, you know, what you said is definitely well taken. But like I say, there are cases that seem to like go back and forth, or at least go in one direction between those three kinds of cases. And of course, we recognize even among the angioimmunoblastic T-cell lymphomas, there are like distinct subsets. But I mean, we're still going to lump them all. But, you know, it might be that those cases with like the IDH2 mutations, maybe they'll need to be treated in a different fashion. And so, you know, I think it's fascinating that, you know, it turns out you can recognize a lot of those cases, you know, from the H&E. So it's telling us something.
So Dr. Swerdlow, the reason being that now I've had IDH2 mutated AITLs, which are not follicular helper T cell type, not the clear-cut ones, because, you know, it's not all three markers as the WHO defines it. It often expresses one of the three or two of the three. So my thing is, if you put it under the follicular helper T cell category, you're making IHC for follicular helper 10 essential to call it AITL, when you know sometimes that IHC is not all three markers are sometimes never positive together. So you still end up calling AITL because you have classical dendritic cell proliferation, you have the other con. So that's just the why, because I do call these cases AITL, and now with the new WHO, I'm wondering what to do.
My advice would be to still call it AITL.
Yeah.
And I mean, I guess the other thing is, I mean, it says at least 2, prefer 3. So, I mean, 2 is okay.
It's
And
fair enough.
I think
Okay,
in
fine.
most of the cases that, I mean, at least in my experience, if oftentimes the PD-1 is positive, and if the PD-1 is positive, the ICOS is usually positive. I don't think it actually adds anything, but then you get to 2. But
Yes.
seriously, I mean, if you've got something that fulfills, your criteria for AITL, with all the things that that you know about, you've taught us about, I'd say call it AITL.
Thank
We
you.
all know there are issues with immunohistochemical stains.
Thank you so much. Thank you so much.
Sure.
Thank you. Dr. Sridhar.
Thank you, sir, for alluding us to the new WHO classification of lymphoid neoplasms. I have a couple of questions. Is one regarding the TdT expression in high-grade lymphomas, the other the conceptual change about Burkitt-like lymphoma with 11q aberrations to large B-cell lymphoma with 11q aberrations. Regarding the first question, sir, we do rarely come across with this TdT-positive blastoid-like transformation of low-grade, especially follicular, sometimes rarely in CLL. Like, what do you do there? Do you still call them as lymphoblastic transformation, or you leave it as a high-grade B-cell, high-grade transformation with TdT expression, especially with new concept of high-grade B-cell lymphoma with TdT overexpression?
Right. So we would consider those cases generally high-grade transformation of the follicular lymphoma to, a high-grade B-cell lymphoma with, whatever, with, BCL2 and MYC rearrangement and with TdT expression.
So your suggestion would be not to call it lymphoblastic transformation.
Right. Right.
Thank you, sir.
I mean, because I think the feeling is that they're so different than classic lymphoblastic leukemia lymphoma.
Okay.
And I mean, they do terribly. And so I think they're worthwhile recognizing. And it's a different disease in many different ways.
Thank you, sir. Coming to the next question, sir, about this conceptual change about large B-cell lymphoma with 11q aberration. Now, what is the point? Like, I have few things about the treatment part. What we understand in the previous classification, that it has been dissected out from MYC negative Burkitt lymphoma, but the treatment is still like Burkitt lymphoma. Now, with this, we can understand the 11q aberration. We don't have any IHC surrogate, like, to call something as specifically as 11q aberration. What is the message like? So some cases look like high-grade B-cell lymphoma NOS, and as per the new literature emerging as they look like DLBCL also. Like, what is a way to address this for this entity? Whether our suggestion to the clinician is to treat like high-grade B-cell lymphoma NOS or DLBL, we don't do routinely for 11q aberration. What is your suggestion? We should do it, or should be treated with R-based therapies, or should be like Burkitt lymphoma?
I mean, I think the message is, first of all, I'm not sure there's an absolute answer to your question at this time. In other words, what is the very best treatment for those cases? I mean, that I don't think that we know for sure. I guess that would be one point. I mean, the other point would be, this is a subset of the MYC negative cases that can look like Burkitt. And, some of them look a lot like Burkitt, some of them don't look that much like Burkitt. I mean, one of the things that can draw your attention to these cases, if it looks sort of like Burkitt and it's got coarser apoptotic bodies. I mean, shown, in one publication. I think the reason the name was changed, was because also just from a biologic perspective, they're really not like Burkitt lymphoma. So, I mean, they are a lot like a diffuse large B-cell lymphoma, and whether the 11q aberrations should then impact your therapy, in other words, treat it with something other than R-CHOP, I don't know the answer to that question. And I'm not sure that anybody would know for sure. Obviously, a lot of these have been treated like Burkitt. But I mean, I think one of our concerns these days in general is that we don't want to be treating people more aggressively than they need to be treated. And, you know, just because it often comes with more side effects and more longer term morbidities. So that's why I think it's a question that needs to be further answered.
So is that mean like if you are not doing for evaluating for 11q aberration, can we still follow the criteria of large B-cell and the blastoid-like morphology as NOS? Can we keep it as for the treatment guide, or what is your suggestion? Especially
So,
for...
I mean, yeah. So, I mean, first of all, like in terms of would some of those cases end up being called high-grade B-cell lymphoma not otherwise specified? I mean, probably, you know, if you don't look for the aberration, they theoretically could be. I would just, you know, I think that the message that you don't want to be diagnosing a lot of high-grade B-cell lymphoma NOS cases. So it's like once in a while, it's okay. But if you're using that diagnosis a lot, you're probably using it too much. So I guess that's the message I would have to leave you with, which is that I do recognize that some of the cases could get called that. I mean, you know, it depends a little bit on how much you're able to work them up. You know, if you do have something that looks like Burkitt and doesn't have a MIC rearrangement, then, I mean, I think the best way to find it would then to do, you know, fish studies or ray studies. But if you're unable to do that, then I think some of the cases will end up being called diffuse large B-cell lymphoma, and other cases might get called high-grade B-cell lymphoma.
Can I have a last one? This is just, what's your special comment about CD20 negative high-grade B-cell lymphomas in immune competent patients? Somehow I find that WHO and ICC both are quite silent. It's not that you may not be coming across with those kind of tumors, but not alluding too much, especially in immune competent patients.
In immune competent?
Yes.
So, so the question is,
CD20 negative high-grade B-cell lymphomas in immune competent patients.
yeah. So, I mean, with CD20 negative B-cell lymphomas in an immune competent person, I mean, you know, you think, I mean, I think about, you know, the things that are more plasmablastic. I mean, you have to make sure you're not dealing with one of those, which would be a B-cell lymphoma, but CD20 negative. And you know, there's a number of those. So, I mean, I would think about that. I would think about these cases that are TdT positive. I mean, because they may lose their CD20. I mean, that's what would sort of go through my mind. You know, could it be lymphoblastic? Could it be plasmablastic? Did someone not tell me that actually the patient's being treated with rituximab and, you know, nobody shared with me the fact that I'm not looking at the person's first diagnostic specimen? You know, of course, we always think about that.
Thank you, sir. Thank you.
Sure.
Dr. Sandeep.
Hello, sir.
Greetings again.
Thank you. It was an excellent talk. My question is regarding subcutaneous panniculitis like T-cell lymphoma. I think, when do you suspect it on morphology, and what clinical features you look for in those patients? And is IHC sufficient to diagnose such cases?
Yeah. Okay. So the question is about subcutaneous panniculitis like T-cell lymphoma. And so, I mean, from a clinical perspective, I mean, obviously you're talking about somebody who usually is presenting with subcutaneous masses, often on the legs, and, without a history of something else. I mean, that's the first step. Then they do biopsy. And I mean, the biopsy's got to be deep enough to get into the subcutaneous tissue. And I think the first thing that I look for, that would make me think about the possibility would be that there's, an infiltrate that's in the subcutaneous tissue and is not going into the dermis. Because there are a lot of things in the subcutaneous tissue that are also in the dermis, and that is not what you see in subcutaneous panniculitis, like T-cell lymphomas. So then, in terms of what is in the subcutaneous tissue, I mean, the things that I look for that make me think about it, with lupus panniculitis being one of the main differentials, would be atypia of the lymphoid cells, the rimming around the fat cells, and the presence of significant cytophagia. I mean, the so-called beanbag cells with histiocytes, with a lot of debris in them. And then, I mean, I would do immunohistochemistry and, looking for that there are T cells, that there's not a lot of mix of 4 and 8 cells, that there aren't a lot of admixed plasma cells. And that would get me pretty close. I mean, I think in a lot of the cases, then we would do T-cell clonality testing, just because, it can be very difficult in the differential diagnosis, especially with the lupus cases. Recognizing that there are lupus cases that people report that are clonal. So again, you put it all together. And I mean, that's basically what we do and what we're looking for. I think, I mean, we've never looked for that HAVCR2 mutation, but I think that will become something that, if it's more available, would be something I probably would do. And because, the patients that have that mutation are ones that seem to, I mean, together with a younger age, do more poorly and maybe at greater risk for hemophagocytic lymphohistiocytosis.
Thank you.
Sure.
Thank you. Dr. Amrita.
Hi, so it was a wonderful talk and very informative. Thank you for that. And some of my questions have already been answered. So I'll just ask one question, that how strongly do you recommend FISH and MYD88 mutation analysis in all the suspected cases of lymphoplasmacytic lymphoma?
Well, that's an excellent question. And
Thank you.
If you had asked me 5 years ago, I would have given you a different answer. But for today, I would say, I don't know about FISH, doesn't need to be done, but the recommendation today is, I mean, if you're able to do it, that looking for a MYD88 mutation in suspected lymphoplasmacytic lymphoma is worthwhile doing, and that it should be done. And I mean, we realize, of course, that the MYD88 mutation is not specific.
Yes.
So you can see it in some marginal zone lymphomas, and certainly in like a subset, an important subset of diffuse large B-cell lymphomas. But the reason that we would do it is, number one, it can be diagnostically useful, again, putting everything together. Number two, the cases that are wild type, where you don't find the mutation, I think, number one, you ask yourself, are you sure it's lymphoplasmacytic lymphoma? And maybe you look back at it and say, well, maybe it really is more like a marginal zone lymphoma. But if you go back and you look and say, no, this is lymphoplasmacytic lymphoma, I'm quite confident, then those wild type cases do seem to be more aggressive and to have a greater chance of transforming to a large B-cell lymphoma. So those are really the reasons that it is recommended that you do it these days. And we do it, quite a bit in those circumstances.
Okay, thank you so much.
You're welcome.
Thank you. Dr. Shashi.
Good evening, sir. I just like to have one practical questions. Like when we classify lymphoma, we have to start from CD5 and CD10. So any recommendation to label any lymphoma as a CD5 negative or 10 negative by using how many antibodies or clone or fluorochrome? Because I get that some cases where the CD5 was negative in the one fluorochrome, when we use a different fluorochrome and different clone, it was coming positive. So it is any guideline or any reference how many clones should be used before to label anything CD5 negative or 10 negative? Because I think one of the last case I have, it was looking like a mantle cell lymphoma, but CD5 was negative in that case. But luckily we have a second fluorochrome and we use in that and it came brightly positive. So I was confidently able to diagnose as a mantle cell lymphoma. So I wanted to know any guideline to use what kind of clone and what kind of minimums should be there, because these 5 and 10 are very critical markers are there.
Right. So, I mean, that's a good question, and I'm not sure that I can answer it really in detail here today. I mean, my guidance is to, use the clone that you find to be sort of most sensitive in general. I mean, we work hard on choosing which clones to use with our flow cytometry. I mean, and I guess to some extent with the immunohistochemistry. So, I mean, I guess that's what I would say, I mean, in very brief, which is that we work hard up front really to choose the clone that we think is going to be the best for us and not overcall things or undercall things. I realize it doesn't always work out quite that way. I mean, I practice hematopathology, and there's what should be and what actually is. But I mean, I can tell you that we don't use multiple clones. We recognize also, I mean, there's phenotypic variation in all of the lymphomas that we recognize. I mean, we do diagnose some CD5 negative mantle cell lymphomas, certainly. And sometimes even deciding what's positive versus negative, especially in our flow studies, is not easy either. So I would say, once you've made the investment up front in deciding what combination of, fluorochromes to use for your different markers, then usually, I mean, we stick with it. I mean, I know of the cases that get sent to us, I mean, many of which have flow done by, big reference laboratories. I think most of them are using, single antibodies. We do, I mean, probably the main thing where sometimes we do use different fluorochromes is with kappa and lambda. Sometimes, I mean, because we, if there's like an issue or a question, sometimes we switch the fluorochromes for the kappa and lambda to see if we can pick up something.
Thank you.
Sure.
Thank you. Dr. Udyan.
Good evening, sir. Excellent talk. Thank you very much. I have a couple of questions, and before that, a small comment on a lighter note that we are now feeling vulnerable to what we have diagnosed 3 months before as NLPHL, being now labeled someone who is reviewing as a non-Hodgkin lymphoma.
Yeah, no, I wouldn't. I don't think you shouldn't worry about it. I mean, it's the same disease. It's the same disease, and I think the clinicians have known actually for a long time that nodular LP was different. So you shouldn't lose sleep over that, because it's basically it's the same disease. It's got a different name. I look back at my reports, they go back a long time. So if you want to feel badly about nodular LP Hodgkin's, I mean, don't look at my old reports, because they'll be even more out and far, far out in outer space.
Yeah. Thank you, sir. So the couple of questions. One is, what is sufficient for EBV-related lymphoproliferation in terms of whether EBNA2 immunostaining is sufficient, or we need to have something else like EBER or something to say that it is, yeah.
Okay, so basically, if the object is to demonstrate if EBV is positive or present or absent, then the best stain is the EBR.
Right.
In situ hybridization, I mean, it's very sensitive. And, you know, there are rare exceptions where it ends up looking negative, where it's really EBV is present. But by far and away, that's the way to go. And that's the, you know, a pretty, I think, universal recommendation.
Yeah.
And so then the question is, what should you do in addition to that? I mean, there's also, like, for people who can't do the EBR stain, I mean, because, you know, it's in situ hybridization and it's more expensive. I mean, then the next antibody that I would use basically is the LMP1 stain, because the LMP1 stain, I mean, is present in at least latency 2 and 3. And I mean, so, you know, latency 2 includes the Hodgkin cases, latency 3, a lot of the immunosuppressed cases. I mean, the problem with the LMP1 stain is I mean, there are classic EBV positive proliferations that will be negative. And even when it's positive, sometimes it's like not on that many cells.
Mm-hmm.
But, you know, if that's what you need to do, then that's what you should do. Then the question is, should you do something in addition to that? And I mean, if you read our paper, basically, I mean, as strongly promoted by Letitia Kintney-Fent, you know, who's seen a lot of these cases, she believes very strongly that people should be doing EBNA2 stains, because that identifies latency pattern 3. And latency pattern 3 is often associated with immunodeficiency, even if you don't originally realize you're dealing with an immunodeficient patient. So, I mean, that's sort of what's out there. EBNA2 by itself would not be satisfactory because it will miss a lot of cases, latency pattern 1 and 2. And I mean, I can just tell you, I mean, we wanted to do EBNA2 stains on a series of cases, and finding somewhere that would actually do it, I mean, because we don't actually do it here. I mean, we've done it for experimental reasons, but we don't do it clinically. And finding someone who could do it for us was actually a challenge. I mean, we finally did. And my point just is that, at least in the United States, I don't think that EBNA2 is being widely used. There are reasons to use it for sure, and it is being more heavily promoted now. But like I say, I'm just telling you, like, you know, what I do, and when I, you know, look at my cases, I'm working without EBNA2 stains. I mean, it sounds like it might be good to do. I mean, you know, for the reasons that I mentioned. And maybe as time passes, more and more people will start doing EBNA2 stains. But if you can only do one stain, as long as you're able to do the EBR stain, then I would do the EBR stain.
Good, sir. Thank you. That answers. And second, and very small question, that can we diagnose mediastinal gray zone lymphoma on a cervical lymph node biopsy where the patient has mediastinal lymph node enlargement, but somehow it cannot be biopsied, which is more often a practical situation?
Right. So, I mean, I think that's a good question. I'm not sure I know the absolute answer, but I think you could certainly still strongly favor that diagnosis, as long as there was a mediastinal mass. I mean, because we know that, I mean, I think the way I would think about it, in a sense, would be like, if you think you could diagnose a primary mediastinal large B-cell lymphoma in that setting, which, I mean, you know, we do, then you should be able to diagnose a gray zone lymphoma. Because the idea is that you have a lymphoma that has these features that sort of are similar between a mediastinal large B-cell lymphoma and classic Hodgkin lymphoma.
Yeah.
That's sort of how I would think about it. And if you say, yeah, I'd be willing to diagnose a mediastinal large B-cell lymphoma in this setting, then I think you could diagnose a mediastinal gray cell lymphoma. I mean, that's just my opinion, but I mean, that's what seems reasonable to me.
Thank you very much.
You're welcome.
Dr. Jyoti. Are you there, Dr. Jyoti? Okay, Dr. Sindhura.
So thank you, Dr. Swerdlow, excellent presentation. Just had a couple of queries. I'm sure you would have heard about these questions before as well. One of my questions is, why have we moved back to multiple myeloma from plasma cell myeloma? And I believe it was the terminology which was used before the 2008 update, the classification. And second one is another of similar changes where you reverted back to the 2003 guidelines that was for the plasma cell and lymphoplasmacytic lymphoma group of disorders. So what was the reason that we have moved back to those times?
Okay, so that's the question. Why are we going backwards instead of forwards? So those are good questions. I think with multiple myeloma and plasma cell myeloma, I think the problem was basically plasma cell myeloma as a name really never caught on. I mean, that a lot of people and in the literature continue to use multiple myeloma. And one of the sort of philosophies, if you will, of our group, you know, meaning the group that worked on the WHO for all those decades and now on the international consensus classification, was that we're really not trying to make things up, but we're trying to capture, you know, what current practice sort of should be. And it seems like, you know, current practice is people just want to call it multiple myeloma. And it didn't matter that much. So that decision was not made based on like, you know, a biologic kind of finding or anything that was new. It's basically, people always called it multiple myeloma. They want to call it multiple myeloma. So let's just call it multiple myeloma. So that's the answer to that. It's not a very scientific answer, but that's basically the reason. In terms of going back to the criteria from the Waldenstrom's working group recommendation, that's, you know, from 2003. I guess, I mean, in some ways you could ask the question, why did we leave that recommendation? Because also, I mean, although, I mean, everything is decided upon, I mean, the fact that the people who are most involved with Waldenstrom's are, you know, believe in that and believe in it to this day is important, you know, when that was discussed. And I mean, I can just tell you that, I mean, I think one of the world's really biggest experts in that area is Dr. Stephen Treon, you know, who's in Boston. And he felt very, very strongly that the patients had, with, you know, now less than 10% involvement in the marrow, as long as you could actually see it. He felt that those patients really, you know, are best off being treated and put into protocols when appropriate for lymphoplasmacytic lymphoma. And I mean, so he felt strongly, I mean, the people he worked with, I mean, in terms of the Waldenstrom's working group, felt strongly that those patients should be handled like a patient with LPL. And that's really the reason that we went back on that.
Thank you.
Thank
Dr.
you, sir.
Jyoti.
I had another question, if I may, sir.
Yeah.
Sir, you have in the ICC, there are two subclasses after the ALK negative ALCL. So is it mandatory that we have to evaluate for P63 and for the further subclassification? Yeah. Is it does it really affect the management?
I mean, it definitely affects the prognosis. And I mean, that's why, especially for the DUSP22, it was recommended. But whether it would actually affect therapy, my guess is that at this point in time, it probably wouldn't affect therapy, although I don't know, maybe some people would handle it differently. But I think the main reason at this time that it was suggested is just because the prognosis seems to be quite different than the other cases. The P63 cases, there's a lot less known about them, although they do seem aggressive. And, you know, so that's not sort of pushed as hard as it could be. I mean, I think it's one of those things that, you know, if you're able to do it, then it's a good idea. If you're not able to do it, I think you can still make a good diagnosis.
Thank you, sir.
You're welcome.
Thank you. Dr. Jyoti, are you ready? Yeah.
Yes. Good evening, sir. Thank you for your wonderful presentation. Sir, in cases of solitary plasmacytoma, do we need to send a bone marrow for IPT to look for minimal involvement? Is it necessary in cases of solitary plasmacytoma of the bone?
So, and with solitary plasmacytoma of the bone, it is very strongly recommended that a bone marrow be done and that flow cytometry be done on that bone marrow. Because when you find involvement, and it can be like very little involvement, but if you find that there are abnormal, you know, monotypic plasma cells, those patients are much more likely to progress. And that, you know, so it does turn it into a very different kind of situation. So that is very strongly suggested.
Sir, another question. In monoclonal B-cell lymphocytosis of the CLL type, should one investigate for tissue monoclonal lymphocytosis?
Yeah, I saw that question, and I think you know, that's something that I would say that, I mean, I think a patient who has monoclonal B-cell lymphocytosis, I mean, certainly should, you know, see a doctor and who would examine them. You know, I mean, so if they had, you know, obvious adenopathy, or if they were sick, you know, that's, I think that's important. I think then the real question, I think that your question sort of infers is, should everybody who has monoclonal B-cell lymphocytosis get like a CT scan?
Yes.
And I think, yeah, I mean, so I think the answer to that is, I think people would tell you no, but that is not a requirement. And, you know, if you do CT scans, then, I mean, you will find some patients that will have, you know, what would then fulfill the criteria for a small lymphocytic lymphoma, or, you know, CLL, small lymphocytic lymphoma. But that is not something, you know, that would be considered something that you need to do.
Thank you, sir.
That's at least my understanding.
Thank you, sir.
Sure.
Thank you. Dr. Parimal.
Good evening, sir. Sir, excellent talk. My question is related to mantle cell lymphoma. Sir, whether the TP53 deletion should be done in all cases of mantle cell lymphoma, or only restricted to the pleomorphic or blastoid variant of mantle cell lymphoma?
So that's a good question. The recommendation is that TP53 analysis should be done in all of the cases. I mean, that's the recommendation. I mean, you know, obviously people are going to have to use their judgment and do what's possible. You know, there may be other features that can be helpful, but I think that the issue is that, well, number one, recognizing when to call a mantle cell lymphoma blastoid or pleomorphic is not always the easiest thing to do. It's very subjective. It depends on how the specimen's been processed. So that, I mean, you really can't count on, you know, that to make too many judgments by themselves, although it's something we obviously all look for and report. And the idea is that if you have mantle cell lymphoma with a TP53 aberration, that those patients really don't respond to typical chemoimmunotherapy. And they need to be handled in some other way, even if the some other way is not as well defined as it should be.
Sir, second question is the role of IgVH mutation analysis in mantle cell lymphoma.
Okay, so I would say, I mean, we know that mutated cases are more like the non-nodal ones. But I would say that it is not a traditional part of how mantle cell lymphomas are worked up these days. So that I think people would more rely on other features to suggest that something was one of those non-nodal leukemic type mantle cell lymphomas. So, I mean, it's a test that might be useful, but I think it's a test that is not routinely being done for clinical purposes. It's a very different situation than with CLL, where that test, you know, is recommended.
Thank you, sir.
Welcome.
So we have 5 questions from the audience. You have time, and if you are not exhausted.
Yeah, I can keep going.
Okay. Dr. Epari has put a question in the chat box. Does doing IHC for MUM1 and P63 protein in ALK negative ALCL have any utility or any surrogate value?
Okay, so I would say doing staining for MUM1 does not have any implications, because it's positive in lots of cases, and it has nothing to do with whether or not there's a DUS22 rearrangement. Doing staining for P63, if the P63 stain is positive, it doesn't necessarily mean that there's a P63 rearrangement. If the P63 stain is negative, then there probably is not going to be one. So I guess I would say that would have limited value. But if you're not going to follow it up with doing the FISH, then it may not be worthwhile, because you'll identify too many cases that you think are going to be very aggressive.
Thank you, sir. Dr. Taha Khan, is the consensus classification same as WHO 5th edition of lymphoid neoplasms? Because there are some disagreements when it comes to myeloid neoplasms between the two.
Right. So that's an excellent question. And I think it's very important for everybody to understand that the ICC classification and what will be in the 5th edition of the WHO are not the same. So exactly what people are going to start doing, I think, you know, we will see. Obviously, there are a lot of very strong feelings here. I mean, so the ICC publications they're all in blood. And like I say, the lymphoid one is available as a 1st edition. It's not the final, you know, it doesn't look like what it'll look like in the journal, but it's out there. Anybody can access it. The myeloid one is accepted, and I'm not positive if it's accessible yet for everybody, but if not, it will be very, very soon, because it's accepted by blood. It just needed, like, you know, the authors to finish their conflict of interest and things like that. And the WHO classification is now available in the Leukemia Journal. There's, you know, the editorial that I mentioned, and then there's a lymphoid paper and a myeloid paper. And the two classifications are different. I mean, they have similarities. Some of the changes in the ICC are also in the WHO, but there are other things that are very different. And so they are not the same. And I mean, so people are going to need to specify probably which classification they're using. And in terms of what will ultimately happen, I don't know. I mean, the belief is that when it comes to the 6th edition, that the person who is in charge of the 5th edition, Dr. Cree, will not be doing the 6th edition. So, I mean, I think there's a hope that maybe with the 6th edition, we can come back together again. Because, I mean, I lived through the 70s and it was not nice about the, you know, different lymphoma classifications. It was hard for clinicians. It was hard for pathologists. There was a lot of nastiness. And I mean, I really hate to see us going through all of that again. But like I say, the main message is they are different classifications. They are not the same, and that you're going to need to specify which classification you're using because the criteria, you know, may be very different for some things. You know, I think, well, I mean, it's going to be a problem for, you know, some entities more than others.
Thank you, sir. Dr. Francisco wants to know, in marginal zone lymphoma, much attention has not been given to IgH mutational status.
Right. So, I mean, with the marginal zone lymphomas, I mean, most of them, although not all of them, are mutated. There's like old literature about the splenic ones and unmutated ones and whether they were worse, but basically it's not something people have particularly focused on, I think, because many of them are mutated. You know, people have looked in terms of marginal zone lymphomas at other mutations, you know, not the IGHV, but in terms of, you know, oncogenic kind of mutations. And I mean, it's an area that people aren't using for practical purposes at the current time, but where there are certainly differences between different kinds of marginal zone lymphomas. And maybe we'll see more of that in the future. I don't really know. But there's, I would say there's more interest in that area.
Thank you, sir. Dr. Allah wants to know about if the lymph node is not accessible and bone marrow is infiltrated with T-cell lymphoma, is there an algorithm to classify the lymphoid infiltrate?
I mean, I think in those kind of circumstances, you sort of do the best that you can. I mean, I don't know of a specific algorithm for dealing with the bone marrow. I mean, some diseases, some T-cell lymphomas are more bone marrow based. Other times, I mean, the bone marrow is what you have to deal with. And I would just say you, as best you can, you apply, you know, your standard criteria. I mean, it's really, I mean, that's a very practical question, you know, I mean, because we all have to deal with it. And, you know, it can be very, very difficult because, I mean, the reality is that a lot of our criteria are really based on the tissue, you know, what these lymphomas look like in tissue. And we know, I mean, like angioimmunoblastic T-cell lymphoma in the bone marrow, I mean, there are certainly very good descriptions about what it looks like, but, you know, it's not looking really for all the same things we look for in the nodes.
Thank you, sir. Dr. Amar Das Gupta wants to know, in a case of follicular lymphoma, how often do you find loss of an antigen or CD marker in the bone marrow as compared to the lymph node?
Okay, so that's a good question. And what I would say is with follicular lymphoma in the bone marrow, I mean, oftentimes you do not see the CD10 expression the way you see it in the lymph nodes. And I think BCL6 stain in bone marrow, especially decalcified bone marrows, is a problem. So you might not see that either. You know, I think the issue is that a lot of what you see in the bone marrow is more like what you see outside the follicles, even in lymph nodes where we know there can be some downregulation of CD10 and especially of BCL6. And I think those are the cells that often end up in the bone marrow. And I think that's probably why you're less likely to see those antigens expressed in the bone marrow.
Thank you, sir. The last question is from Dr. Manasi. This is regarding mature lymphoid malignancies. What is the minimum NGS panel that you would routinely recommend?
Oh, that's a great last question. And I can't honestly give you a good answer. I mean, I think that's a work in progress. I mean, some people are using smaller panels, other people are using larger panels. Most people are using no panels. I mean, it's, with the myeloid side, a lot of people are using NGS panels. On the lymphoid side, it's much more limited. I mean, we have insurance issues here. So I think that will continue to evolve. I mean, and it also depends on the situation. So, I mean, if you're looking to try to further substantiate the diagnosis of one of the TFH lymphomas, I mean, a panel that just includes, a very limited number of, genes, like the RHO-A and the TET2 and the IDH2 and DNMT3A and maybe a few others. I mean, that would be, sufficient in that setting. But if you're looking for, at a diffuse large B-cell lymphoma, it's totally different. If you're looking to distinguish, different kinds of follicular lymphoma or, follicular lymphoma from pediatric type follicular lymphoma, it would be a different set of genes. And we really haven't resolved, should we be doing lots of little teeny panels or one larger panel? I mean, it's still fairly expensive.
Thank you, sir. That was the last question. I'm flooded with the compliments. Everyone has appreciated your lecture. They have been sending messages by WhatsApp, email, SMSs, and put in the chat box. It was fantastic 2 hours of deliberation, your lecture, and then patient answer to all these questions. Tremendous, sir. Thank you so much for being with us and educating us. This is, I don't know how many times you have done it for us. Extremely grateful to you.
Well, and I want to thank you also for having invited me these, several times, because this is what I really enjoy. I enjoy talking about what I love, and I really enjoy interacting, with people and being able to have a conversation, answer their questions as best that I can. And I have to say, I mean, as I think about, this part of my career, that one of the very most rewarding parts of what I've done and what I've tried to do is being able to have friends around the world. This is really important to me, and it's really what I have found to be the most rewarding. So thank you so much to you and to everybody who is here today and who I've met before. You have helped me so much, have a nice life and a great career. And I'm just very, very grateful and honored.
Thank you, sir. Have a wonderful weekend. And I also thank our sponsors, NATCO, and the event manager team of Kalpesh, Yash, and others. And thank you all the faculty for making it so lively. Wonderful. Great weekend. Bye-bye.
Bye-bye. Thank you so much. Good night. Have a nice weekend.
Thank you, sir.